This is Open to Debate. I'm John Donvan. Hi, everybody. Around this time last year, the American Academy of Pediatrics put out a press release where the first sentence sounded an urgent and concerning kind of note. It began by saying, more than 14.4 million U.S. children and teens live with a common chronic disease. It then went on to say that that disease is obesity. The Academy had just published a new set of guidelines for treating kids who are overweight or obese, as defined by a measurement called the BMI, the Body Mass Index. And in general, while acknowledging that there's an interaction of all kinds of factors involved in kids putting on weight, the guidelines also called for early intervention, including trying to change what and how kids eat early, including the use of drugs, think Wegovy and Ozempic, for kids who have reached the age of 12, and including bariatric surgery for kids who have reached the age of 13 if their weight is at the higher end of the BMI range. Right out of the gate, these new guidelines proved controversial, and in the months since, the arguing has not abated one bit, with disagreements that are as much philosophical as they are medical. Given that the health of millions of U.S. children is at stake, physical health as well as mental health, this was an argument that we've been wanting to visit in the way that we do at Open to Debate, by hearing from two people who know what they're talking about, who disagree with one another, and who we are counting on to hear each other out and to challenge one another in good faith. So here we are in time for National Nutrition Month, ready to ask this question. Are the AAP's child obesity guidelines good medicine, or are they too extreme? So let's meet our debaters. Arguing that the AAP's childhood obesity guidelines are good medicine, we have Dr. Julia Nordgren. Julia is a pediatrician who specializes in childhood obesity, cholesterol issues, and nutrition. She's an attending physician at the Stanford Weight Clinic, as well as the lipid and weight management specialist at the Palo Alto Medical Foundation. She is also a trained chef and has a cookbook called The New Family Table. Welcome, Julia, to Open to Debate.
Thank you so much. It's wonderful to be here.
And arguing that the guidelines are too extreme, we also have another pediatrician, Dr. Jana Giwertz-O'Brien. Jana provides care to adolescents and young adults at the Hennepin Healthcare Clinic in Minneapolis, and she teaches at the University of Minnesota Medical School. She also serves on the executive board of the Minnesota chapter of the American Academy of Pediatrics, so she is not opposed to the AAP in general. Welcome, Jana, to Open to Debate, and you have a little bit of a disclaimer you want to make on that last point, I think.
Yes, I want to say that I'm here for the youth and families I work with, but I do not discuss the views I discuss today do not represent the University of Minnesota or the Minnesota chapter of the American Academy of Pediatrics. These views are my own.
Okay, thank you for that clarification. And I want to ask you something else, a question I actually want to put to both of you. I'm always interested when we have people on the program who want to work with children, whether those are teachers or therapists, and in your case, medical doctors. So I'm just curious what motivates you when you got into this field to want to work with kids. And since you were the last to speak, Jana, why don't you go with that question?
Sure. So I came into the field of pediatrics, and specifically, I'm a specialist in adolescent medicine, meaning I'm an expert in adolescent and young adult health, ages 11 to 24. And I came into this field because I love walking alongside young people and their families and supporting them as they grow and seeing them develop into humans that love themselves and actualize their identities and goals. That's a big part of why I'm here. I'm also a physician activist, and I recognize that a lot of what I do extends well beyond the work that I can do outside in the clinic. And I do a lot of that work actually with the AAP, and a lot of that work alongside the young people and families I work with. So right. I'm really lucky. That's why I'm here.
You care. It's very, very clear. And Julia, we know you care as well, but I'd just like to know, again, the origins of your interest in working with kids.
Yeah, I am very similarly minded. I think so many of us go into pediatrics because we have the opportunity to be with children and walk them through the most critical parts of their lives. And I think another wonderful thing about pediatrics is that we can all always be on the same page. We want these kids to be healthy. We want their parents to enjoy them. We want these kids to grow up to be healthy and strong. And these kids come in with someone who loves them and cares for them. And I think adults, they're a little harder to take care of. They got their habits. They might not care so much, but kids, they come with a very caring parent almost always. So that's a big feature.
I am hearing some common values, but we are here to debate. So we're gonna
We
we're gonna
are.
be listening to you disagree on a couple of things, and we want to hear what those things are right now by moving into our opening statements. And in our opening round, each of you gets up to 4 minutes to explain why you're taking the position you are. Julia, you're up first, and again, the question is: are child obesity guidelines good medicine or too extreme? You're saying good medicine. Tell us why.
Oh, yes. Well, these are great medicine. So, as you know, I have been taking care of kids with obesity for 2 decades. And finally, dawn is breaking on a new era of obesity management for children and adolescents. This new beginning was really ushered in by the AAP with these practice guidelines. And they are so well researched, they are so well intentioned. These are long overdue guidelines, and they help us. They understand the science behind obesity, the complications, and the complexities of caring for these patients, and what treatments might actually help these kids get better. And, for so many years, we've all struggled with caring for children with obesity. It's hard to talk about. No one wants to have a conversation that makes parents feel blamed or makes kids feel embarrassed or ashamed of themselves. It might be more comfortable just to be hopeful and optimistic that, they'll just grow out of it. But the problem is that just doesn't work. There is no evidence that supports watchful waiting as an effective treatment for obesity. This is a disease that most kids will not outgrow, and the longer we wait, the worse it will get. And here are the facts. A child who has obesity by age 3 has a 90% chance of being an obese adolescent and adult. A 12-year-old with severe obesity is virtually guaranteed to become a severely obese adult. And a severely obese adult, we know they have a shorter lifespan, they have a lower quality of life, and they're riddled with health issues, diabetes, early heart disease, infertility, obesity-related cancers. I mean, the list goes on, and these are real problems. And we just can't pretend that these kids with obesity are just happy and healthy kids with a high measure of weight for height. These are kids that many of them are really suffering. They're tired, they don't feel well. These are kids more at risk for depression and anxiety, high blood pressure, sleep apnea, back pain, leg pain. And these kids are teased. I mean, they're teased not only on the field, in school, in PE class. They're teased by their siblings, and they're teased by their parents. It's such a hard problem. And the stigma about obesity, it's so real. And we really need to address that. But in the meantime, we need to understand something important. Obesity is not a matter of willpower. This is not a moral failing on the part of children. This is a disease. And this is not a disease only for parents who don't care about their kids. I mean, really the opposite is true. So here's what it is. Obesity is a multifactorial, chronic, relapsing disease. It has genetic underpinnings. It has environmental, societal inputs. And it's a disease state that lies in the hormonal and neurologic pathways that control appetite and energy regulation. And as the body develops excess adiposity or fatty tissue, these pathways reset to maintain and preserve the new body mass. So this altered energy regulation system is the physiologic root to this disease. And of course, it can be stabilized somewhat with diet and exercise changes, but these hormonal and neurologic systems are altered, and this has lifelong effects for children. But thankfully, we have some new effective tools. We have medicines that are so promising. They are so effective. We have surgical treatments that lead to durable weight loss and a true reduction of disease burden for these kids. And the AAP guidelines are a roadmap for us, and they help us as caring, compassionate pediatricians do what we do best. We can treat kids expertly with empathy so that they have the tools and the treatment that they need to have a long, healthy, and amazing life.
Thank you very much, Julia. And Jen, it's your turn now. You are arguing that the child obesity guidelines are too extreme. This is your turn to tell us why.
Yes, thank you. So, as a board certified pediatrician and an adolescent medicine physician with expertise in eating disorders, these guidelines are too aggressive. Recommending intensive and potentially harmful interventions for up to 1 in 5 children and adolescents is dangerous. And if implemented, they can cause serious harm to children and adolescents in the short and the long term. Think about the kids and teenagers you know in your lives. Their bodies are changing. They're figuring out who they are. They're navigating a complex world that's full of messages telling them what they should and shouldn't look like. They're hearing online and offline that their bodies are a problem and that thin bodies are an ideal that emerged and has been emerged 3 to 4 decades ago and has been internalized into the fabric of our society in the form of diet culture and a massive, highly profitable diet industry and pharmaceutical industry. These guidelines, again, suggest that 1 in 5 of these children and adolescents and their families should hear the message that their bodies are not okay at every single healthcare visit with their doctors, and that they should receive aggressive medications and or weight loss surgery. Again, that's 1 in 5 kids that we're telling that message to. I take issue with 3 major points in the AAP guidelines. First of all, the guidelines suggest that medical decisions hinge on the basis of body mass index, or BMI, which is an inherently flawed measure that is not a reliable surrogate for health. It was developed as a population health measure, interestingly, by a statistician and astronomer, and it was primarily developed among white men in the 19th century in Belgium. Even the American Medical Association made a statement in June 2023 recognizing issues with using BMI as a measurement due to its historical harm and its use for racist exclusion in the years that followed its development, and because BMI is primarily based on data collected from previous generations of non-Hispanic white populations. It also doesn't account for muscularity, which is why many muscular people are told that they are, quote, severely obese. And it doesn't account for puberty and variation in normal body size, which are both really important during the adolescent years. Second, even if we were to assume that everyone living in a larger body were a problem and that larger bodies are a problem and are all sick, these aggressive interventions, including weight loss pills in children as young as 12 and surgery for kids as young as 13, are potentially dangerous, are just not that effective in the short or the long term, have major risks, and we have very little information about how they affect growth and development among children and adolescents. They're expensive. They're also difficult to sustain, even if they are funded, and stopping them leads to rapid ups and downs in weights, called weight cycling, which we know are actually dangerous for health. Finally, there is evidence that eating disorders can and do emerge as a result of weight loss interventions. And I see young people in my practice all the time who develop disordered eating after hearing from their doctors that their weight is too high. This is such a concern that the Academy of Eating Disorders and several other large eating disorder organizations immediately put out a statement opposing these guidelines. With 50% of female adolescents having engaged in some form of disordered eating, we need to take this seriously, and yet the guidelines fail to mention eating disorders beyond a single statement and did not include any people with eating disorder expertise, or for that matter, anyone with lived experiences of eating disorders or any fat people in the development of these guidelines. And finally, I'll close with this. These guidelines reinforce weight stigma and the thin ideal, which is rooted in racism, classism, and sexism. Weight stigma and anti-fat bias and discrimination are a threat to health. In fact, in 2017, the AAP put out a strong policy statement titled Stigma Experienced by Children and Adolescents with Obesity, as we heard from my colleague, and outlined the physical and mental health effects of experiencing stigma. It's associated with social isolation, avoidance of healthcare, decreased physical activity, poor mental health, increased morbidity and mortality, independent of a person's excess weight. And I'm going to put that in quotes. These guidelines acknowledge that, and yet they do almost nothing about it beyond saying, this is a problem, we need to address it. So in summary, I am very concerned about the impact of these guidelines on the children and adolescents I work with every single day.
Thank you very much, Jana and Julia. Now we know where each of you stand and why on the question that we're asking. The child obesity guidelines, are they good medicine or too extreme? We've heard opening statements from our two debaters, Julia Nordgren and Jana Gewirtz-O'Brien, both pediatricians. Julia, whose work with kids focuses on issues related to obesity, and Jana, who works with adolescents. What I heard you saying in your opening arguments, again, I think it's clear that you both have the best outcomes for kids in mind. You both like working with kids, and you're very committed to it. But you have a fundamental disagreement about certain aspects of these guidelines. Julia, I hear you saying that you think they're good medicine because they're well researched, they address the science, that in fact the responses that are being discussed puts new tools, recently especially in the hands of doctors, to actually have an effective and durable impact on kids who are seen as putting on too much weight. You make the point it's not about willpower, it's about biology, and that the biology needs help and that the help is there now, and you're in favor of putting that in place. And if that's not happening, you are concerned about the 90% of kids who are obese remaining obese through the rest of their lives and bringing in a rash of health problems that we're all familiar with, including diabetes, heart disease, shorter lifespan, and certain kinds of cancers. Jana, I'm hearing you saying very, very fundamentally message that having a larger body does not mean that you are sick. You find these measures to be too aggressive, especially as they would apply to 1 in 5 children. You're saying that their impact could be dangerous, that they're built around the notion that a thin body is an ideal, and you're arguing that it's not. You point out that the BMI is flawed. It doesn't account, for example, for muscularity. In the therapies themselves, you're saying, and the science is not really that clear that they are effective in the long term. And there's also an impact on mental health and physical health, with the possibility that when kids feel stigmatized by being told that they need to lose weight, that can result in eating disorders. So there's a lot to dig into there. And I want to go back to you, Julia, and ask you very fundamentally, what do you think would be the outcome of a world in which these guidelines had not been issued, or, if they're so criticized that at some point the AAP would rescind them? In other words, you're talking about the good of having these things there. What's the bad of having them not there?
Well, the bad of having them not there is we're just rudderless as physicians, that we just don't have any science or effective treatment or parameters for having clear discussions about what might really be going on with these kids. I mean, the argument that we're telling kids that they're sick, that's just untrue. If kids come into us with a high BMI or an abnormal pattern of weight gain, kids who have gained weight throughout the pandemic, these kids are coming to us with concerns, with abnormal growth patterns. That's our job. Our job is to do pattern recognition. As pediatricians, and Jana knows that you don't ever look at one moment on the BMI and say, well, you're severely obese. I mean, that's just absurd to think that caring pediatricians are using this as the only measure of counseling parents or patients on whether or not they have something that needs to be fixed. If we don't have clear evidence-based scientific guidelines that help us have conversations about treatments, we're just sitting watching these kids develop early diabetes, early heart disease. I mean, your kids in clinic, you're seeing kids with PCOS and trouble, menstrual irregularities. I mean, these are problems that are rooted in obesity. So
what I think I hear you saying is that the status quo is unacceptable because the status quo is resulting in more kids having these issues and having them into adulthood. And I want to take that to you, Jana, that something needed to be done. Something dramatic needed to be done. Do you agree that something needed to be done at around or before the time these guidelines came out?
Well, yes, I think something dramatic does need to be done. I think doctors, including us, need to look inward at our own bias and look inward at our own stigma and the harm that we've caused. And I think actually we both agree on this. There is immense stigma in healthcare. It's documented that 1 in 4 nurses with which a person interacts thinks that a person living in a larger body is disgusting. It's documented that people as young medical professionals starting in medical school think that people living in larger bodies are lazy, aren't doing what they should be doing, and will make poor decisions about their health. And this has been documented over and over again in the literature. So yes, I do think something dramatic needs to be done. It needs to be us looking inward. I also just want to tackle for a second something that was said. It was said that our job as doctors is to help to do pattern recognition and to watch. Our job as doctors is to help young people grow and thrive. And right now, what I've heard loud and clear is that helping young people growing and thriving means telling them on the basis of BMI and BMI alone, and let's just be clear, I want to point that out. These guidelines are saying if somebody is overweight or obese and doesn't have any of the comorbid, even if they do not have any of the diseases that Julia mentioned, that they should still be recommended medications as young as 12 and referred for bariatric surgery as young as 13 on the basis of a number alone, which is BMI, which is flawed, racist, classist, and sexist. So it is a problematic measure that we are hinging a large discussion on. And people living in larger bodies, people who identify as fat, feel this. Even if we say, this guideline has us talking out of both sides of our mouths. On the first few sets, they do this great job of laying out obesity as a multifactorial disease, just like Julia did. And I'm like, yeah, absolutely. And then they're like, and young people, they experience all of this harm and stigma. Yes, we agree.
Jana, I'm jumping in just because you've said so much. I want to let Julia respond to whatever part of that you would like to first, Julia.
Yeah, I hope we'll get back to that discrimination piece, though. Okay.
Yeah, we will. We will, actually. So
Absolutely.
I'm putting a pin in that. Yeah. Julia.
Yeah, of course. I mean, the discrimination piece, we should absolutely put a pin in that. And weight stigma is so real. And I think part of that is it stigmatizes us and it can be paralyzing. Then you don't want to have a conversation. You don't want to address something that these kids are thinking about. It's on their minds. These kids are suffering from complications. And the assumption that a pediatrician that recognizes a high BMI that isn't using their clinical judgment to say, actually, you're extremely muscular. Nobody's going to take that extremely muscular football player that doesn't have abdominal adiposity or true adiposity.
Can you explain the term adiposity for folks?
Sure. Adiposity is deposition of storage fat, so deposition of fatty tissue. So adiposity is a marker. Adiposity just means fatty tissue. So the argument here is hinging on having a larger body is wrong. Well, that's just untrue. Bodies come in all shapes and sizes. We're pediatricians. We understand that and we celebrate that. The key thing here is what is causing disease in the short term and the long term. It's abnormal development of excess adiposity. Is BMI a perfect marker of excess adiposity? No. BMI does weight. It's a measure of height for weight. So it does not take into account it doesn't take into account, muscularity. It doesn't take into account breast tissue, glandular tissue, density of bones. There's so much that's unaccounted for. But it actually is the best, cheapest, most effective marker or measurement that approximates excess adiposity that is harmful fatty tissue that causes disease.
So, Jana, if you could, I have a question I want to follow up with you, but I want to give you a chance just to respond to Julia's defense of what she says is flawed, but is just a kind of beginning guideline, the BMI. If you could take 30 seconds on that, because you've already made it clear that you're not too impressed by that data point. But if you can take 30 seconds, and then I want to ask you a question after that.
Yes. So BMI, I've already shared, developed and has been primarily validated in white non-Hispanic populations. It cannot be broadly applied. It also doesn't account, like we were talking about, for puberty. So applying this measure and then hinging decisions on it, major medical decisions, recommending medications with a high side effect profile and a high likelihood of rebounding and immediately gaining that weight back, which leads to weight cycling and causes health, is dangerous. The other piece is this guideline specifically doesn't actually include any studies that look at anything else aside from BMI. They excluded specifically any studies that focused on lifestyle changes alone, even though the American Heart Association themselves has documented that specifically physical activity and cardiorespiratory fitness are actually great predictors of health over time. So the point is, there are better predictors of health, but the thing that matters most in a conversation between a pediatrician and a child and a family are the physical behaviors, like moving more, like eating consistently, like developing a healthy relationship with food, not this very flawed, historically racist and problematic number that doesn't really correlate well with health now or in the future.
But are you suggesting that Julia's position is that the BMI is the be-all and end-all? Because I don't think that's what I hear her saying. I think she's arguing that it's a starting point.
Julia's position is stating that BMI should be taken in context. These guidelines, however, specifically state one of their key action statement is that on the basis of BMI alone, even with no other unhealthy, any documented evidence of disease like diabetes or heart disease, that someone should intervene. So I think Julia's statement is absolutely what pediatricians should do. Take it as a small point in time. And I think many pediatricians in this course of a 20 or 15-minute long well visit are saying, sorry, your BMI is too high. It's a problem. We need to intervene. And then they're intervening with potentially problematic statements that include weight stigma.
I want to get on to some other topics, but I just want to ask you, Julia, do you want to say anything else about the BMI in response to what's just been said? And if not, that's okay.
Yeah, I think BMI it's really an excellent marker. I mean, regardless of its historical beginnings, I mean, that's a whole other conversation about everything in medicine. But yeah, BMI actually does when you look at BMI trends over time, you can see if their BMI is rising in a way that's higher than what is predicted and normal for their age. We have normative values. We understand normal patterns of growth, and we can see this. You're doing a physical exam. I think you're missing the point that if it's just BMI is a very, very good surrogate marker of excess adiposity that causes problems. It should be taken with all these other things. So I don't think the beginnings of
the normal. It's not about the origin, though. It's also about that it's primarily been validated in predominantly white non-Hispanic populations in the last 20 years, and the norm that we're applying is a one-size-fits-all approach that doesn't recognize the wide diversity of bodies that exist among adolescents and deviations in when puberty begins across different populations. And it leads to people being mislabeled and labeled as diseased, as having a chronic illness, even when they followed along the same curve for BMI, even by our normative values, for their whole lives.
But that's just not correct. That's just not correct.
That is correct. I see it in my practice all the time. Tell that to the young person I saw earlier today who was told that her body was a problem, even though she's trended at the 95th percentile for her whole life, and then rapidly lost 20 pounds after starting a weight loss medicine and is profoundly malnourished.
I'm assuming you're seeing a girl with an eating disorder. So this girl has a different disease. So she's talking about a girl with a different disease.
It is not a different disease.
A 20-pound weight loss is anorexia. That's a different disease than obesity.
I want to be clear.
Go together. They sometimes go together, if you'll let me finish. These diseases go together. We are not comparing when we're looking at a BMI chart for someone who is Black or Hispanic or Asian or white, we are not comparing their BMI in that moment to a white child's BMI at a different moment. We are comparing their BMI to their prior BMI, to their prior BMI. We are looking at trends for them and them alone. We are not pitting one racial group against another racial group. We are not discriminating against a child because they are white or because they are Black or because they are Hispanic. We are looking at their body mass index. We are assessing their excess adiposity and their personal risk of disease in the present and in the future. We are not in those clinics exhibiting racist behaviors when we're assessing a child and their health and well-being in the moment and making risk assessments for the future.
Let's move on. Let's move on to beyond the BMI question to the type of response question. So the guidelines also call for the use of pharmaceuticals for 12-year-olds and bariatric surgery for 13-year-olds if they're at the higher end of the weight range. You made the argument, Jenna, that the science really is not in on the impact of the pharmaceuticals. Can you take a minute more to explain your position on that?
Oh, absolutely. So certainly people have been trying these different types of pharmaceuticals in children and adolescents and adults for a long time. And in fact, every time there's a new pharmaceutical on the market, it seems like there is kind of a craze about it. This came up with fen-phen. It's documented with many other ones that have gone on to be very, very dangerous. But I'll run through a couple of the pharmaceuticals, and I'm sure Dr. Julia will too. We'll look at them together. The ones I'm very concerned about, I'll start with, are the ones that have more recently come out onto the market. Wegovy, which you mentioned, being recommended for children. This has certainly not been evaluated over a long period of time. It has certainly been a weekly, well, just to back up, it is an injection that occurs weekly. the studies on it originally in adolescents actually screened out anybody with any mental health concerns. There's high rates of GI upset with it. There's some speculation about poor mental health outcomes with it. But I think the most important thing with it, aside from being extremely expensive and profit driven, and most of these studies being highly profit driven, is that after more than 2 years, most of these adolescents, as soon as they discontinued it, gained the weight right back. And weight cycling itself is not actually something to be taken lightly. It is potentially dangerous. It is associated with a higher risk of all-cause mortality, meaning these rapid ups and downs in weight. And actually, it's thought that a lot of the correlation that Julia was talking about between weight and physical disease is, at least to some extent, attributable to this idea of weight cycling, meaning we're currently going on diets. Things like Wegovy and other medicines like phentermine and topiramate that are utilized in adolescents lead to lots of rapid weight cycling. They lead to distorted patterns of behavior, and they don't do what Julia advocates for in her blog, which are like developing a healthy relationship with food over time.
Okay, let's let Julia in on this.
So that's where I'd go start off, and we can go
Thanks.
from there.
Julia, you're in.
Well, I'd like to point out that these things can and absolutely should be done at the same time. And any pediatrician or any physician who's prescribing weight loss medications without advocating and working and talking constantly about developing a healthy relationship with food and giving advice and talking about that, first of all, if you're not taking time to talk about that, you're not worth your salt as a pediatrician. That is our job. We need to be helping kids love their bodies, accept their bodies, care for their bodies. Developing a healthy relationship with delicious, nutritious food is a foundation of that health. And if you don't want to talk about that, then I mean, not you, Jana, but my patients, if they don't want to talk about that, I mean, that is the foundation of health. So anybody who is getting a prescription for weight loss medications, if they have a good pediatrician, an educated pediatrician, they have done their work of lots of counseling about what is the healthy relationship with food like? How can I improve that? What do you feel like? What are your flavors that you love? How can I help
Julia,
you with habits?
But where are you on the challenge to the impact of the medication that Jana brought to you?
Okay, so first of all, a healthy relationship with food goes hand in hand with weight loss medications. These are not diametrically opposed. They should be done together at the same time repeatedly. One interesting point that Jana makes is that this weight cycling, going up, going down, is harmful. So let's be clear. Chronic obesity is a harmful disease. Left untreated, it causes medical problems. Kids who are obese have concurrent problems. They have joint pain, they have back pain, they have sleep apnea. If we treat this disease for 2 years, so like any chronic disease treatment, when you treat it and then you stop treating, yes, that disease comes back because it's a chronic disease. So I hear you arguing, which seems implausible, that, oh, you should just stay obese because if we treat your obesity and then it comes back after 2 years, well, that could be bad for you.
All right, time out. I want to ask Jana if that is in fact what you're saying. That's an interesting crystallization of your argument.
That's actually not what I'm saying. What I'm saying is, if we teach kids to love, what you're proposing is that they go on a medication that is potentially harmful and dangerous with a large side effect profile that also names their illness, names their body as an illness, and pathologizes their body. And then they go on a medication that potentially causes harm. And then, as soon as they go off the medication, they go back to the prior, almost always go back to the prior curve that they were on, or back to the prior growth trajectory they were on.
Jana,
That's not a return of the disease. That's a return to the body that was a healthy weight for them potentially.
But it wasn't.
And they're recommending, but you haven't actually said that though, because these guidelines are only making this point on the basis of BMI alone, which is a flawed measure. They're saying to use it even in kids without diabetes, without PCOS, without obstructive sleep apnea.
So you want to wait? You want to wait for them to get PCOS? Do you want to wait
things that
until they're
you're-
infertile and having babies that are large for gestational age or small for you want to wait for them to develop obesity-related cancers? I mean, that's one way to look at it.
First of all, I think the notion that all obese people are sick just needs to be called out right now. Not all obese people go on to develop illness. If we look at the numbers here, first of all, 30% of adolescents who are obese are not obese at 30 years of age. Second of all, there is a phenomenon, and I wanted to say 40% of adults who meet criteria for obesity are actually have no cardiometabolic disturbance whatsoever. So we're providing an aggressive medication early on for diseases that primarily do not actually cause harm until at least later into adulthood to prevent these alleged diseases that they may or may not develop in adulthood. When we intervene, we're causing potential harm with medications and surgery. We haven't gotten there yet. And potentially promoting poorer mental health, reinforcing weight stigma, reinforcing societal norms that the thin body is the better body, and potentially promoting eating disorders, which is why almost every eating disorder association said, oh my gosh, these guidelines are going to make these kids sicker. And let me just tell you, eating disorders are among the most fatal psychiatric illnesses and cost millions of dollars to our society. And no, they do not. You made this point that eating disorders are separate than obesity. 50% of young people with anorexia have a history of obesity in the past. So these are inextricably linked, and the AAP says it too. In the previous
on both of you,
excuse me.
They do go together.
Time out a second.
Not always.
I just want to
They
let
do
you
go
know.
together.
That's not true.
They do.
Totally
50% of people in bariatric surgery clinics have a history of binge eating disorder. We absolutely see these going together. We need to be thinking about them together, and these guidelines do not even address them.
Jana, in fairness to Julia, I've got to let her break in, and that's what I want to say is that I don't like interrupting speakers, but I'm only doing it in each case because you're both very passionate but going on at length, and a lot gets said. So I want to give Julia a chance to respond, and then I have a question for you, Jana, that I think is sort of fundamental to your point or to our understanding your point. But
Okay.
Julia, take a moment. Go.
Well, I'll tell you. I mean, I'll just tell you a quick anecdote. I have many, of course, but so I have a kid who has severe obesity, and his obesity is so bad that he will need a hip replacement, and his teasing at school is so relentless. These bullies at school, you know what they do? They kick him in the hip, the bad hip. I mean, the relentless teasing and the harm. He has erosive hip disease from his obesity. I would be so irresponsible to try to teach this boy to love his illness. That's just love your back pain, love your diabetes, love your stretch marks, love how it feels to be totally winded when you're running in PE and you can't keep up with your peers. These are real physical problems. This is not that the child is bad or the child needs to be solved. You're the one that's saying a thin body is an ideal body. No, I have never said that. No, and people who believe that are that's just not the case. No pediatrician that practices compassionate expert care will tell a child that their body is a problem and it needs to be fixed. Obesity is a metabolic and neuroendocrine disease that can go along with many other diseases. That is the root cause of a lot of these other problems. It is the root cause for diabetes. Heart disease, a heart attack doesn't happen in one day.
I want to put this question to you, Jana. Essentially, to quote what Julia just said, that obesity is a disease. The AAP statement says obesity is a disease. Do you believe that obesity is a disease when you say that a large body does not mean you're sick? Does it ever mean you're sick? The largeness, the weight, is it ever a disease?
I think there are certain people who have a higher BMI that also have illnesses, and that those illnesses, including the hip pain that the kid you're talking about experienced, should be treated as they absolutely should. These guidelines hinge and they label as somebody with an elevated BMI alone or carrying excess weight alone as having a disease, and that is just not true to the nuance of the reality. That is true. I want to also just touch on one other thing, which is I think really important here, which is this bullying piece. Bullying and experiencing weight stigma, which is a form of discrimination based on size, our response to that should not be, let's make you thinner. I'm taking out the point about the hip pain here. Absolutely. Kids with hip pain should be treated for their hip pain. But bullying is not a reason to aggressively treat somebody for medications. Bullying is a reason to undo the thin ideal in society and to work towards a better and freer and more affirming society inside and outside of healthcare, where people love themselves, love their bodies, and learn and develop a healthy and nourishing relationship with food and move in an enjoyable way. Bullying, the answer to racism isn't isn't straighten your hair and assimilate. The answer to transphobia isn't conversion. The answer to size diversity and size discrimination is not be thinner and change yourselves. It is be who you are, and we are here to help and support you in your health when those health issues come up.
Okay, I had said we would get to the discrimination point, and I'm glad that you opened up that part of the conversation. We're going to bring in some other voices now to ask some questions. And first up, we have journalist Elaine Chen. Elaine is a cardiovascular disease reporter at STAT. Elaine, welcome. Thanks for joining us on Open to Debate, and come on in with your question, please.
Hi, thank you so much for inviting me on. So my question, and we've sort of touched on this, but I'm asking this question to hopefully help if there are any doctors or parents listening on the call, that hopefully it might be useful information for them. Is there a way to provide and treat children and adolescents with medications, particularly some of the new ones like Wegovy, without causing harm to their mental health and body image issues and raise the risk of eating disorders? Is it possible to have both at the same time? And if so, what does that look like? As a pediatrician, how would you go about trying to carry that out?
Julia, that sounds to me like a question that's directed initially to you, though I'd like to also hear Jenna's response to your response to it. But Julia, why don't you just take that on, please?
Oh, yes, it can absolutely be done. I think that what we don't give enough credence to is that a lot of these issues of depression and anxiety have roots in societal factors, environmental factors. Kids with obesity, because they have a physiologic alteration in their energy balance, so their energy system gets set to protect their altered fat mass, they often come with a sense of frustration, a sense of hopelessness, a sense of why being not good enough. Why is this not getting better? I've been trying so hard to eat better and to exercise more, and I'm just not seeing the results. That's so depressing. So if you can pull in a medication as an adjunct, again, it's not a replacement for any of those things, but if you can provide all of your great care with your lifestyle foundation, your exercise. And frankly, some kids have such high obesity that they're really physically unable to exercise effectively. And so in an ideal world where you want all these things to be in place, a medication can be an extremely effective adjunct to their care plan. And these kids see, wow, I can lose weight. I am eating better. I am feeling more hopeful. And so the kids that I've treated in clinic have across the board, in my practice, this does not apply to everyone, experienced improved mental health, more hopefulness, more determination, and feel not that they've fixed a problem, but these children have said to me in different ways, I feel more like myself. This is the person I want to be. I feel great. I feel energized. I'm going to my formal. I'm going for lead designer of yearbook. I feel better, more hopeful, more determined, and my mental health is better. That is my clinical experience, which has value.
Yeah, Jenna, if you could take that question on, and again, I'm hearing Elaine asking not so much now about the effectiveness or long-term consequences on the body, but on the mental health impact of being encouraged or guided to using medications to lose weight. And Julia's saying she thinks the mental health impact is actually quite positive. I know that you've already alluded to you thinking the opposite, but can you take it in more detail?
So I think you asked if it's possible to give medications and not promote disordered eating with medications, which is a different story. Absolutely. In an ideal world, we have pediatricians that have worked to dismantle their own internalized weight bias. We have long-term conversations with families promoting a balanced approach to movement, to developing a healthy relationship with food, and we're supporting young people's mental and physical health during the process. That is in an ideal world. That is not what most people who are living in larger bodies experience when they're getting these medications. So yes, Julia described an ideal world that can occur and that that could exist. But we're talking about 20% of people put on metformin with GI side effects. We're talking about being put on phentermine, which is not a medicine that's safe for pregnancy. And these are, again, young people in childbearing age. And a potentially dangerous medicine that actually has been associated with increased anxiety and prolonged periods of fasting followed by binge eating. We're talking about medications like topiramate, which are associated with cognitive slowing, which can affect schoolwork and function. And we're talking newer, Wegovy, I hate even using the drug company names, Wegovy, and medicines like that also have potentially harmful side effects with young people, including changes to the way their bodies function. So yes, in an ideal world, we would also be promoting one's body image and discouraging disordered eating. But those medicines don't act as a high side effect profile and potentially lead to that higher risk. And we don't do a great job screening for eating disorders either. And then I want to make one more point on this, which is that the rebound weight gain is high. And I've worked with many young people who stop the medicines when they're required to. For instance, phentermine needs to be stopped after 3 months. They gain the weight back and then they're like, well, now I'm a failure. This medicine didn't even work for me. And that is the majority of people that get these medicines. The weight does not stay off long term. I do want to just acknowledge here that we have no one living in a larger body in this room or in this space talking about this right now. If we did, they would say that they were told over and over and over again that their bodies needed to change, and they would speak about these weight loss stories too. Feel free to go on, listen to the Maintenance Phase podcast, listen to those podcasts and hear them talk from their own voices rather than listening to us talk about this. These medications are potentially harmful, dangerous, and they do promote disordered eating, and there is evidence that they do.
Well, that's a very interesting assumption you just made. How do you know the body that I'm living in? How do you know the body that I have lived in? You're making assumptions. You are judging me based on what you see on my picture. So yes, I think if you're talking about weight bias, then where is your weight bias? Well, how do you know?
I'm making an assumption because you haven't disclosed anything about your identity, and we haven't started from a place of relative positionality.
Well, why would I?
Here.
We're in a safe space. We're in a safe space. My body is not relevant in this conversation. We're talking about children with obesity. We are talking about children with an endocrine disease, a neurologic disease. We are not talking about how we feel. The reality of how weight loss medications work and are administered, that is the reality. The ideal world that you described, that's my real world. The world where kids are treated horribly by doctors or experiencing weight bias, certainly that needs to be worked on at the same time. We can't wait for the world to be perfect in order to treat children with a disease that overlaps with perceptions that aren't true for them. It is not true that kids who have obesity are lazy, are bad people who don't care about themselves. There are so many assumptions that are made by seeing people with obesity. That is awful. That needs to change. The guidelines that the American Academy of Pediatrics set out for the evaluation of children and adolescents with obesity is not a document about how we can and should go about fighting weight bias and weight stigma, which is a horrendous problem. And I go to bat for these kids. You wouldn't believe what I do to try to make these kids' lives more comfortable. I write letters to PE teachers to say, hey, don't force this kid into an embarrassing situation. The cruelty is real. But in our offices, the AAP guidelines are giving us some clear, expert, well-researched scientific parameters on medications that actually are effective at treating the root cause of this disease.
Julie, I'm jumping in on the matter of time, and you've made that point already. And I just want to, since you did say quite a bit there, I want to do one more round with Jana if she would like to respond.
There was a lot said there, so I'm trying to kind of figure out where to land here. So first of all, I am making assumptions based on appearance because we didn't say that identity piece. I just want to name that, yes, your world sounds great, and I think you seem like a great person. It's not an affront to you. What I do think it's an affront to is that there is well-documented evidence that children and families are hearing every time they go to the pediatrician that their bodies are not okay, even when they don't have associated illness. And you keep bringing this back to associated illness, but that is a minority of patients. The reality is that associated diabetes, obstructive sleep apnea, polycystic ovary syndrome, and heart disease that you're describing are primarily, though they can occur during adolescence, primarily are diseases that cause mortality and morbidity later in life. There is no harm to waiting until the person is an adult to have these conversations. There isn't. I saw the eye roll. There isn't. And there isn't. This is a critical window of development. We don't know how these medications affect young people during puberty. We know that Wegovy primarily takes from bone and muscle, or takes 40% of weight loss from bone and muscle, which we don't know how that impacts. We know these medicines aren't safe for young people who are potentially going on to bear children. And we don't know that these medicines cause side effects even in the moment that I hear from young people all the time affect their physical and mental health and well-being. We're treating something that we've labeled by BMI, again, a flawed measure. We're treating something with that. We're sending the message that young people's bodies are not okay. And then we're doing it with medications that don't work very well, have a high side effect profile. This is, okay. I know in your beautiful world, like this is, you see success stories. Yes, those exist. But most people
I'm jumping in.
have
Again, I'm
effects.
jumping in because you've both made the points that you're making now, and we're pressed for time. Elaine, thanks for your question. I want to bring in Mackenzie Prilliman. Mackenzie is a freelance science journalist whose work has appeared in Nature and Science News, among other places. Mackenzie, thanks for joining us at Open to Debate, and come on in, please, with your question.
Hi, well, thank you so much for having me today. This has been a fascinating debate. So I wanted to just ask, let's say that there are some very thorough doctors who have checked their internal biases and have determined that their adolescent patients' health might very much benefit from these more intensive treatments, anti-obesity medications, bariatric surgery, even, just mental health counseling. These are expensive and time-consuming treatments. How do we ensure that kids and teens in lower socioeconomic households even have the opportunity to participate in these kinds of weight interventions?
Julia, do you want to take that first?
Sure. This is like a crazy evolving landscape. Yes, these medications are very expensive. And I practice in California, and in this kind of beautiful twist of irony, I'm able to access important treatments for kids and offer them. And I have fewer insurance barriers on kids who are on our health plan, who have poverty and who qualify for health plans. So it's just one of those strange but wonderful opportunities that I have. And it's interesting that the harder times I have when I want to advocate for a child to receive treatment because they have severe disease, they have complications, when my clinical judgment and working with the family, I will say this is always shared decision making, that the benefits of treatment along with the risks of treatment outweigh the risks of not treating and the benefits of not treating. So we're always doing this very, very careful weighing. The money is a really, really big issue. It will change when some of these medications come off patent, when they're more available. We could talk a lot about the pharmaceutical companies and the price gouging, and it's a really huge problem. That's a whole other conversation that should be had. What is going on? Why are these treatments not universally available?
Let's use that point to let Jana jump in if you'd like to on the same question, Jana.
Yeah, I'm glad you brought this up as an equity issue, because I think it is an equity issue across the board. The drivers, as this guideline, and I think we agree on this actually, the drivers of obesity are of obesity as a number, and also of the correlating diabetes and heart disease, are in fact structural inequities in our society. A lack of access to nutritious foods, structural oppression, trauma. In fact, we know that discrimination, racism, all of those increase the stress response, which, as we've talked about, is a physiologic part of all of this, right?
Absolutely.
So these structural inequities are a driver of the diseases that Julia and I both have talked about, and also of this higher BMI and this distribution in weight. There's also cultural, racial, and ethnic differences in the way that bodies are and their sizes that are here, and that also contributes to some inequities. I want to note that earlier on, I was not implying that anyone individually in any of these doctors' offices is individually inherently racist. It's that the structures of BMI itself is an inherently racist measure. It's embedded in there. Just by the way that it's there. Now, on to your really good question, which is, even in a society where every single doctor has grappled with their own weight stigma, which I wish would happen. I think we both actually wish that would happen because we're both there. Like, I think we agree on that. We're talking about the three interventions that we're talking about are intensive behavior and lifestyle treatment. That was one that was recommended by the AAP, which requires, of note, 26 plus hours of face-to-face time over the course of 3 to 12 months, which, as somebody who works primarily in a predominantly almost all public insurance or uninsured practice and also works with youth experiencing homelessness, nearly impossible for almost all of my patients to physically implement. And also, again, there's that rebound weight gain right after because it's remarkably difficult to sustain. And then there's these very expensive medications and also bariatric surgery, which again, this is driven, I just want to name, by a large capitalist enterprise that has convinced us that we need to be aggressive here. That's part of this. And also has a lot of profit to gain from this. So yes, we have the equity issue is the driver of obesity in the first place, but there is also an equity issue in who can actually access these and who can access the foods that we're talking about and who has access to green space and who has safe communities and who is experiencing a tremendous amount of toxic stress related to various intersecting identities of oppression, like being Black, being gay, being queer, and being fat. Actually, as part of that list. So people, when they experience these things, experience inequities that are driving this. I think I'm
seeing quite a bit of common ground in response to that.
We have a lot of common ground, clearly.
I want to thank you for that, Mackenzie. Now let's bring in Tristan Justice, and Tristan is the Western correspondent for The Federalist. He's actually working on a book about the obesity epidemic in the U.S. Tristan, thank you for your patience in waiting, and come on in with your question, please.
Research suggests that half the nation will be obese by the end of the decade, with severe implications for the future of chronic disease. Are you at all, and I know there's been a lot of talk during this conversation about weight stigmatization, but are either of you concerned at all about the complete destigmatization surrounding excess weight, that it might normalize food addiction to the point where even more aggressive innovations will be needed in the medical industry to combat weight gain? Or do you believe that we should maintain some level of stigmatization on the same level as we stigmatize something like smoking?
I disagree that we should further stigmatize people because stigmatization is associated with poorer physical health outcomes, poorer mental health outcomes, avoidance of going to the doctor in the first place. I was just talking to well, hold on. I'm just going to quote Taylor Swift. She said, shame never made anybody less gay. Shame also never made anybody less fat. Okay? I do want to make one more thing here that I need to call out one more point he said that I think is important here. He made the assumption that all people living in larger bodies are addicted to food, which I think both of us can plainly say that food addiction is actually not a driving cause of obesity. The driving cause of people living in larger bodies and that number going up are the structural factors and the multifactorial factors we were talking about earlier, and that the AAP actually really does a good job of outlining in this guidance. Like, they talk about the multifactorial basis of this disease. So no, shame will not help. It will just harm. It will cause more eating disorders. It will lead to more suicide and depression, and it will lead to poorer health outcomes. The opposite of what we want. Smoking is a risk behavior. Living in a larger body is a physical characteristic. And we should not discriminate against them. No.
Julia, you're up on this one.
I think it's a really, really tricky question because I think that we're somehow equating stigma and shame with avoidance of behaviors like eating and health, which I just don't think is a logical or scientifically sound assumption to make. I think we have normalized a lot of behaviors, not necessarily related to body size, but related to the habits that can create a larger body size. As an example, we've normalized being too busy to cook for our families. We've normalized eating on the run, the relentless advertising of fast food. I mean, my kids are exposed all day to negative food environments, unhealthy food environments. It is so hard to do what Jana and I both want kids to do, which is develop a healthy relationship with food. How do we do that as physicians or as families when the moment you walk out the door, you're bombarded with, eat this, get this quick, get on the run, cheap, quick. That's what you want. Is that what we want? I think that's the bigger risk.
Tristan, thank you for your question. And that is a wrap on this portion of the program. And now we go to the home stretch. The home stretch is a closing statements from each of you, making up our third round. In that section, you each get up to 2 minutes to make one more time the argument that you're making that these guidelines are good medicine or too extreme. And Julia, you're up first. Again, you're arguing that they are good medicine. Please tell us one more time why you're taking that position.
Well, thank you so much for this amazing conversation on the great medicine presented by the AAP guidelines. And just to be clear, these guidelines aren't saying that anybody at this particular size should be prescribed a medication. They should be offered a conversation about treatment options, which may include medication and surgery. So we are pediatricians. We are the adults that care about these kids and are more invested in their health and well-being than anyone outside of their families. Our offices should be safe places, and we need to treat our patients openly, honestly, and respectfully. Whether they have obesity, asthma, or diabetes, we have effective treatments. And no treatment is ever perfect or without risk. But not offering conversations and education about these treatments that offer treatments at the root cause of their disease, the neuroendocrine hormonal disruption of altered fat mass, avoiding that doesn't serve our children. And that is not good medicine. And I'd like to leave you with the words of a parent of a 16-year-old who is currently getting medical treatment for her obesity. And she wrote me a beautiful letter. And in that letter, she wrote, "I can't express to you how much this treatment has helped our daughter and our family. Our relationships have improved, our stress levels are reduced, and dinner time is no longer a time of anguish. She still has a long way to go, but treatment has transformed my daughter at a time where high school, social challenges, and general teenage life demand so much. This has been an ideal time to break negative habits that were setting in on the mental and physical front. I know my daughter will continue her journey with the hope and determination that she was lacking before. For that, we are so very grateful."
Thank you very much, Julia. And Jana, you get the last word here, your closing statement to tell us why you think these guidelines are too extreme.
Okay, the time is now for those of us in healthcare to actually take a good look inward to be skeptical about what we've been taught, about flawed racist measures that don't reliably predict health, to recognize the harm that we've caused with this very weight-focused and obsessed paradigm. We did actually, I know that Dr. Julia made the argument that BMI, that no one would ever make a decision about surgery or medications without the full context, but that is actually not true. The key action statement in this guideline says, on the basis of weight, of BMI specifically alone, that we should intervene with potentially very dangerous, aggressive, and expensive interventions with a high profit margins for 1 in 5 children. We're talking about medications, and we didn't even get to the point about bariatric surgery that we're recommending during a critical window of development when we actually know very little about the short and long-term impact on their health. I also would like to close with the story of a young person I work with. I'll de-identify it, and it's an all too common story in my practice. It's a story of a sweet 15-year-old Latina girl who played soccer and volleyball, who had been told her whole life by doctors and by almost everyone around her that her body was too big. She received multiple trials of medications that worked momentarily and then, quote, failed, leading to her to feel defeated and like she had, quote, failed. By the time I saw her, she was struggling with an eating disorder and was starving and malnourished. We needed to do so much work to get back to a place where she actually could have a healthy relationship with food and movement and her body again. What patients need to hear from their pediatricians, they need to hear from us that we affirm them, that we support them, that we care deeply about their health. We should not be creating spaces where they're afraid to come in to see us because we're going to talk about weight no matter what, even when they come in for appendicitis. We need to let them know that we are here for them and that we care about them and that we want them to love their bodies. So where do we go from here? We need to urgently work to create a world where doctors' offices are affirming, safe, and supportive. In pediatrics, we need approaches that de-emphasize BMI and refocus on health and health behaviors. We need to encourage youth to nourish their bodies, have a healthy relationship with food, engage in movement that they enjoy, and love their bodies and who they are. What I'm describing are the tenets of a weight-neutral, health at every size approach, which has actively been studied over the last 3 decades. This is where we need to go in the future. I'm going to close with a quote by Sonia Renee Taylor's book, from Sonia Renee Taylor's book, The Body is Not an Apology. What if we all became committed to the idea that no one should have to apologize for being a human in a body?
Thank you, Jana. And that is a wrap on our debate. And I want to thank everyone who participated, starting with my fellow journalists, Elaine, Mackenzie, and Tristan, for bringing in your interesting questions, getting us to an interesting place. But especially, I want to thank our 2 debaters, Julia Nordgren and Jana Gewirtz O'Brien. It was so clear throughout this debate, and people who couldn't see were not able to see how often you were actually smiling at one another, as fierce as the conversation got. It's so clear you have shared values, but that in the areas where you disagreed with one another with such deep respect, which is the thing that we aim to prove here at Open to Debate is possible in the way that we talk with each other. So you were such fantastic examples and also shed light on understanding the issues before us. So I want to thank both of you so much for joining us on Open to Debate.
Thank you for having me.
Thank you. Thank you for having us. And yes, it wouldn't be uncommon for us to now go to coffee and just learn from each other and enjoy each other's company.
Yeah, we probably will.
We would actually.
Yes.
And finally, a big thank you to you, our audience, for tuning into this episode of Open to Debate. You know, as a nonprofit, we are working to combat extreme polarization through proving there is such a thing as good argument and civil debate, and that work is made possible by listeners like you, and by the Rosencrantz Foundation, and by supporters of Open to Debate. Our chairman is Robert Rosencrantz, our CEO is Clea Connor, Leah Mathau is our chief content officer. This episode was produced by Alexis Pangrazi and Marlette Sandoval. Editorial and research by Gabriella Mayer and Andrew Foote. Andrew Lipson and Max Fulton provided production support. Mili Shah is Director of Audience Development. The Open to Debate team also includes Gabriella Iannicelli, Rachel Kemp, Linda Lee, and Devin Shermer. Damon Whittemore mixed this episode. Our theme music is by Alex Clement, and I'm John Donvan. We'll see you next time on Open to Debate.